Well, welcome everybody, and thanks for joining us again on another Thursday night. Really appreciate your support, supporting us in these webinars, and we've got another great lineup tonight, and hope these Thursday nights might provide a little ray of educational sunshine on what's been a pretty grim few weeks, especially for those of us up here in Auckland. They've let me back this week. There's no greater vote of confidence for an organisation these days in being able to choose the virtual Zoom background. So pretty privileged and honoured to be allowed back into our Zoom account. And yeah, look, I hope you're all well wherever you are. Increasingly, it sort of seems like our lives are being sort of held somewhat virtually hostage by a bunch of non-compliant gang members as opposed to the compliant gang members. And so given that dealing meth isn't an essential service, we can only hope that they're conducting such businesses in a contactless fashion. But you do wonder if they could use some of their recently acquired government funding to at least do some saliva testing or get a proof of a negative test before dispensing goods to their clients. So if there are any patched gang members on this webinar, then welcome. And our level 3 SOP is available on our Facebook page, and you, like everybody else on this call, are welcome to use it. So just bear that in mind if you are one of those individuals. We'll start off tonight with the usual housekeeping. I'm sure you all know where your own toilet and fire exit is at home, but just for the purpose of the webinar, we'll try and take some questions as we go. Please use the Q&A function. Don't use the chat, and that allows us to then maybe get some questions answered live, and we'll answer some by typing the answers as well. So got a really good lineup tonight to talk about osteoarthritis. Adam Castricum, Hannah Crosswell, and Paul Monk. About 15 minutes each with some time for some questions. And we're going to kick things off with Adam, who's, as you may have known, is from Melbourne, but he's pretty much a paid mole for Queenstown Southern Lakes tourism. He just loves it so much. And we'll allow him to talk about his approach to osteoarthritis and kick us off. Thanks, Adam.
Thank you, Dan. And thank you, and kia ora, everyone. And yeah, welcome, and thanks for joining us again on a Thursday night. And I guess I'm down in Queenstown. We're in level 2, and thinking of everyone up in level 3 up there. But also, it's over in Australia. If you're calling in from Australia, particularly in the eastern states. So I've been asked to talk about an interdisciplinary approach to the management of knee and hip osteoarthritis. And I guess, you know, I've come from Australia where we see a lot of this, and I've moved over here. So just getting used to how this is the practice and how it sets up down here. This is just up on the snow about just last week. It was actually quite nice. So we've still got a bit of a season down here, which is quite good. So we're still seeing people out there hurting themselves. Osteoarthritis in Aotearoa, it's the most common form of arthritis that we see. It affects 1 in 10 New Zealanders. Most of you will know this. It's one of the leading causes of disability and loss of well-being. There's high hospital costs, and what's really struck me here, how it's sort of quite poorly coordinated in the community, because it doesn't really come under ACC. Sometimes it does, if it's post sort of traumatic or ACL, but it's generally quite poorly funded. As far as the Māori population, the relative risk of osteoarthritis is 1.25, and they often present earlier. But interestingly, they have a lower arthroplasty rate. Healthcare costs, this comes from Haxby Abbott and Ross Wilson. This came out in sort of 2019. Healthcare costs for arthroplasty is 199 million, 2013, 2038, almost going to double. And similarly with the arthroplasty rate. And Baldwin in 2017 said an osteoarthritis model of care should be a national priority for New Zealand. Because, yeah, sort of where does it fit? It's the interesting thing is that there's going to be a new health system in New Zealand in July 1 next year, 2022. So it's a really interesting sort of time to sort of work out how can we get the best model of care for all of New Zealand and all of the community. Australia realised this about 10 years ago as well, because their costs of managing this was skyrocketing. It was one of the highest costs for hospitals, yet it was sort of down as far as urgency in the bottom 10. So the GPs did a full Delphi consensus looking at everything and came up with the things that were really strong in evidence. And we know about these, that education, land-based exercise and weight management. And we know that there's great data to show that if you lose 5% of your body weight, this is for knee pain, you can reduce your pain by 30%. If you lose it by 10%, you can get up to 50%. So that's pretty strong. You don't get that from anti-inflammatories. There was another one recently about if you lose, I think it was 7.5% of your body weight before a total knee replacement, you can actually delay that in about, I think, 30%. So it was interesting that to do that. And the strength stuff also helping if you do your 6 weeks of 2 physiotherapy structured strengthening programs, that can help to reduce your risk of knee pain, I think, by about 30%. So they're the things that are what we've got to be doing first up. Basically, what they're saying is don't refer for arthroscopic procedures unless a patient has true mechanical locking. And in Australia, they've taken away the number for arthroscopy, and it will only give the rebate if you have locking or to clean out a loose body. So that's only just come away. But also just around surgical management, when you might do it. Traditionally, what's happened is, you know, in Victoria, they had an early a model of care. What sort of model of care should we have? Early disease management, ongoing disease management, and then advanced disease management. So that was what they sort of working on. That was a guy, Andrew Briggs, who's an excellent researcher in Melbourne. And basically what they decided is that everyone should be getting the big one, non-pharmacological care, non-surgical, education assurance, as I said, pain management, exercise and weight control. Some get the pharmacological care, which includes drugs and injections, and only a few should get surgical care. Now, I'm not saying we're going to get rid of surgery. We're going to still have it because the population is still going to be there. It's going to need it, but it's just getting the right person to get the right operation at the right time and trying to get them in the best shape before they do have an operation. That's the most important thing to ensure that we get good success rates. So that was from the Victorian model of hip and knee OA care. So it works out, it's a team effort. Traditionally, certainly in some parts of Australia, I'm not sure in New Zealand here, but there's still this sort of, if someone's got knee pain, we refer them off to an orthopedic surgeon for treatment. We'd like to sort of shift away from that. So it's a team model that we need to be using. And I guess when we look at this, these are the groups that can be involved. All of us should be able to prescribe lifestyle, whether it's weight loss, exercise, and educate people about things. The pharmacological stuff, leave that to the doctors, and the surgery, leave that to the surgeons. And that's where it sort of sits here. But what we'd like to see, but also, because as I said here, here's the weight loss and everything else here. So all that, these are what everyone should be able to do or talk about. And then I guess the pharmacology, I'm talking about injectables here. Look, at the end of the day, that's end brain, the end sort of stuff, and should only be after seeing a specialist. We all should be sticking to getting the basics right up the top. And again, what the surgeons can do here, and the other thing I didn't put in here is where it's bariatric surgery for those who are obese. In New Zealand, what have we been doing? There's some work that was done in 2015. The Ministry of Health here wisely said, "Oh, let's commit 50 million to this over about 3 years to try and better prevent and for the care of musculoskeletal conditions, including osteoarthritis." So it's not just osteoarthritis. Spinal conditions was also osteoporosis. 44 million of that, so it's about 80% went to the surgery. And 6 million went to, let's work on a mobility action plan, which was improving the care for those with musculoskeletal conditions. And it was based at trying to get into early intervention, community-based, evidence-based, and multidisciplinary care. So sort of similar to this diagram on the right here. So the entry point is not just into surgeons here, but the entry point is going through sort of a public health organisation where they're triaged, referred to GPs, podiatrists, counsellors, physiotherapists, dietitians, educators, and only some of those referrals would go to specialists. And I guess sport and exercise physicians, rheumatologists fit here, pain physicians, and then surgery here. And, you know, I think that sport and exercise physicians particularly have very good relationships with our orthopedic surgeon colleagues and know when and probably not when to get someone in there. And the other thing about this is it had to be a priority for Māori, Pacifica, and those least able to access it. So it was all about equitable access, because what we find in Australia, particularly, is that the access to a lot of this is whether you're well off and you've got access to private insurance. It's actually not great. So similar sort of issue here, and they did that for 17 pilot sites, and we're still awaiting a report to see how that's that's coming through, but we're expecting something to come through from the government shortly. So I guess where we want it to be is that surgery circle gets a bit smaller, and this big lifestyle thing, everyone gets better at doing this, and the pharmacological, we're not so reliant on those. So I guess that's in a nutshell where the model of care needs to go. Now, when I moved over here 6 months ago from Australia, when Mark Fulcher asked me, do I want to be on this an osteoarthritis, New Zealand osteoarthritis summit working group. And so I've been really sort of honoured and privileged to be working with wonderful people across all disciplines, whether it's from physiotherapists to Arthritis New Zealand, orthopaedic surgeons, and also rheumatologists and researchers. And so I've been involved with this, and we had a base camp on the 10th of July up in Auckland just before everything went down into lockdown. And we actually had a great discussion there. David Hunter from Australia, who led the Australian model of care development, he spoke to us. And so we had a great day there, just presenting what's happening, what's the research, and I guess novel delivery of care models. This was the Australian model of care that they came up with that took them about 4 years. And you'll note that they put prevention in here first, which is great. We shouldn't forget prevention. And so these were the priorities that they had across Australia for there's seven priorities there. A lot of it was about prevention, supporting primary care, but also improving the community-based care for non-surgical management, and also making the right decision around who gets surgery at the right time. So that's the sort of model that we've got to look at, but it's going to be a bit more than what we're doing here. So this is the steering committee. It's called OSCAR. Our key objectives are to co-create a national model of care for osteoarthritis in Aotearoa, and to develop a prioritised list of national priorities in terms of research here, and also innovative health delivery. And we've already come up with a few things. My joint pain has been adopted by Arthritis New Zealand, and there's also a good guidebook here for education, which is, I've got to say, one of the best clinical guidelines I've seen. It's culturally incredibly safe and incredibly relevant. You wouldn't get that in Australia, sadly, but it's great to see that this is here. And where you can find out about this, we're looking to have the summit now in July of next year, and it looks like it's going to be in Wellington. And if you go to this website, you'll be able to get the emails for Haxby, Abbott, Daniel O'Brien, and also for Sam Norman, who's involved. So I encourage you to look at that. If you want to be involved or get more information about that, please contact any of those, and they will be able to add you to our mailing list, and we'll give you more information to that, whether you want to present at the talk or run posters, but that'll be in July next year. So that's what's happening in New Zealand and Aotearoa. We're working on getting this model of care coming together. So I'm hoping that I can help to bring some, I guess, Australian flavour to it, but also some bringing some flavour from the College of Sport and Exercise Physicians, which is, of course, across Australia and New Zealand. And we've launched this in Australia recently, the Moving Medicine movement. And a lot of it is about prescribing exercise to help with musculoskeletal conditions and all chronic diseases, really, including osteoarthritis. And it's interesting because a lot of people with osteoarthritis also have multiple comorbidities, whether it's mental health or other issues. So it's really important that everyone exercises regardless of whether they do have osteoarthritic pain. So that's coming in New Zealand, so look out for that. And I will just leave it there. So thank you, because it's now timely for Hannah to talk about exercise prescription. So thank you, Hannah.
Adam, I've actually got one question for you. How do you find, what effective strategies do you find in terms of changing people's conception or misconceptions about what osteoarthritis is? This idea that I've got this condition that's just going to see me crumble into the dust and turn into granny or granddad with a walking stick. What strategies do you find that are useful to getting people to understand that there is a purpose to these active interventions, and that you're not just dealt this hand that's going to continue to get worse and worse?
It's a good question, Dan. I think what I've learned over the years is that we need to redefine the word pain. I think the hospital construct of pain is that if you have pain, you ring a buzzer and you get pain relief. And that's certainly how Big Pharma model it. We need to get away from that and actually start to be comfortable with having a little bit of pain or an ache. We talk about sort of, the VAS scale of 0 to 10, and that, 0 to 2 is more of an ache. or a niggle, and 2 to 5 is okay. And certainly the research done by Ewell Roos and her group in Scandinavia show that it's safe to actually exercise with those sort of levels of pain. And we just have to accept that that's what you might have, and it's not disabling. It allows you to still function. And there's great research now coming out that people with a little bit of pain or even MR findings in their hip and even knee can continue to exercise with higher loads, whether it's running, and they're not actually damaging the joint. They're not actually making it worse. So pain is such a multifaceted sort of word. I don't actually like the word much anymore. And I think we need to be better at explaining what it is and when it's safe to actually do things with your joints. Because I think if we can make people feel comfortable with a little bit of discomfort, then I think that we are going to make great strides in managing this, that it's okay to have a little bit to actually get somewhere. And it also, sometimes your joints may get a bit sore when you start to exercise on them. It's not a reason to stop doing what you need to stop doing.
Sounds good. Yeah, it's really a challenge, isn't it? I think when you meet people, they've got this preconception about what osteoarthritis means, and if you can break through their misconceptions, it's a lot easier to get buy-in for things that will help. So that's great. And look, this will be a really important piece of work over the next few years in helping shape the care of arthritis in New Zealand. And I know that ACC are involved as well, because of the overlap between sort of the acute injury and then the underlying process. So it'll be nice to get that tidied up. So it's thanks for that, Adam.
And if I could just answer Pip's question quickly. She talked about research around blood injections before embarking on a rehab program. Look, I think it's important to build the rehab program first and try to reduce the pain. Absolutely. And then there might be a place for PRP injections. There's another systematic review that say that's probably better than a placebo, cortisone or HLA, or the hyaluronic acid injections. But again, you'd be trying off with other pain limiters before you start injecting those joints. So I'd be trying the rehab beforehand, and certainly the weight loss before you'd even start to get into those injections, because they're not covered by insurance. They're $500 each. And as I say to every patient, whether it's here or in Australia, I'd rather you spent $500 on rehab, whether it's physiotherapy or strengthening or a weight loss program, before you spend it on a injection into your joint. You're going to get more bang for your buck from those non-injection interventions. So
yeah, that's a good point. I changed my philosophy around supplementation for some of these things a while ago, when I started to realise that people were happy to spend buckets of money on some glucosamine and hadn't yet bought an exercycle. So I think that opportunity cost is a good point. So yeah, thanks, Adam. All right, look, keep those questions coming through. They're really good, and yeah, we'll endeavour to answer them live when the speaker's talking, if we can, and then we'll catch up with them afterwards. So next up, we've got Hannah Crosswell. Hannah is our resident clinical exercise physiologist. She's a fantastic addition to our team up here at Axis, and I think many of you may or may not be aware of exercise physiology. It is certainly slightly bigger in Australia than it is here, but I think as we look at some of the disease management process and we shift towards a thought around prevention and exercise as a medicine, we're going to hear a lot more about exercise physiologists. She is accredited with Clinical Exercise Physiology New Zealand and the ACSM, the American College of Sports Medicine, and she does a lot of work for us with our exercise as medicine and our concussion patients as well, which is fantastic. And Hannah's also very knowledgeable about skincare, which is very helpful in the online era. So don't put those questions in the chat, maybe put them offline, but if you want to looking good on Zoom talk, we'll get her in for that on another time as well. But I'll hand over to you, Hannah. Thanks very much.
Thanks, Dan. Share my screen. That's worked okay. Cool. So yeah, I'm Hannah. Thanks for tuning in tonight. I thought I would just give a bit of an explanation around what my role as a CEP is, because as Dan alluded to, sometimes I get a few confused looks when I say what my role is. So CEPs specialise in the delivery of exercise, lifestyle and behavioural modification programs for the prevention, management and rehab of people with chronic conditions and diseases. So I'm just going to talk a little bit about my approach to using exercise as a rehab tool in patients with OA and some of the considerations that are important to the management of these patients. So I won't spend too much time going over the basic kind of background of OA because Adam's just done a great job of that before. So just quickly, OA is obviously the most common form of arthritis and accounts for about 85% of arthritis diagnoses. 1 in 10 adults in New Zealand have OA, and we're seeing a rapid increase in these stats as an ageing population, and also increasing rates of obesity and joint injury are contributing to the lowering of the age of onset from the early 60s to kind of early to mid 50s. OA tends to occur due to damage to the joint surface as a result of trauma, abnormal biomechanics, or repetitive joint stress. And that damage progresses and the joint space narrows even more. That underlying cartilage experiences abnormal stress and deforms, resulting in symptoms such as pain in the affected joint during or after movement, as well as altered joint function, so things like stiffness, swelling, and that kind of grating sensation. There are some risk factors that we can address to reduce our risk of developing OA, so things like obesity. However, there are also some that are non-modifiable, such as gender and age. The last few years have seen a fair amount of research start to look at the prevalence of comorbidities in individuals with OA, and the findings are pretty clear that this cohort tends to have a high prevalence of comorbidities. So a recent meta-analysis of 42 studies showed that 67% of individuals with OA had at least one other chronic condition, which is about 20% higher than those without OA. The most common comorbidities included hypertension, stroke, cardiovascular disease, and diabetes. This is important to note because the presence of multiple chronic conditions in a single individual often causes higher mortality, increased hospitalization, impaired physical and mental health, worse disease outcome, and poorer quality of life. Clinically, comorbidities in OA create greater challenges for management, and the number and pattern of different comorbid conditions determines the severity and burden in patients with multimorbidities. Unfortunately, many individuals experiencing arthritic pain stop exercising, with the thought being that exercise will worsen the symptoms and disease. Obviously, we all know that inactivity leads to muscle atrophy, loss of joint range of motion, increased pain, and can also result in the development of comorbidities such as hypertension, obesity, and CVD. The good news is exercise is an effective, non-invasive, and easily accessible treatment strategy for all of these conditions. And specifically with OA, we know that it helps to reduce joint pain and stiffness, improve muscle strength around the affected joints, and prevent functional decline, as well as improve quality of life. So if we're going to implement exercise rehab in a safe and effective way in this population, then we need to be aware of what these comorbidities are and how they might affect an individual's exercise response. So there are very few contraindications to exercise for people with OA, the main ones being previous injury or acute flare-up. And to be honest, most of the time in those cases, modification of activity is often preferable to actually stopping activity altogether. The main components of an exercise program for those with OA should include aerobic training, resistance training, and neuromotor training in order to improve cardiorespiratory fitness, strength, stability, range of motion, and proprioception of the affected joints of the surrounding muscles, as well as target any of those modifiable risk factors that may prevent the development of comorbidities. So we'll delve into some specifics around this a little bit later on. What I thought might make it a bit more interesting as I went through the different considerations around exercise assessment and prescription would be if I did it alongside a bit of a case study. So I'm just going to pop some information up from an initial assessment with one of my patients. So before a patient comes in for exercise testing, I will have conducted an interview with them. We do a free 30-minute consult where we can gain a thorough medical history and get an idea of what their current physical capacity is, as well as what they're hoping to improve on over their time with us. And that's really helpful and actually necessary to make sure that we're appropriately assessing the exercise tolerance and that we can form a safe and effective exercise prescription based off the data that we'll get from the testing we do. This will also involve some behavioural interviewing in order to gain an understanding of the patient's motivations for exercise, as well as hopefully identify any barriers that might get in the way of their regular participation so that we can address those early on in an attempt to minimise the impact they might have on the patient's exercise adherence. So I've just listed some of the info there. So we've got a 69-year-old female. She's recently retired from a pretty sedentary job. In terms of previous medical history, she had an arthroscopy with a right partial mastectomy in 2007, which had a pretty good result. Unfortunately, she had a fall in 2018, which affected the same knee, and she had some persistent right knee pain following that and was diagnosed with OA. She was recommended that the next step would probably be a total knee joint replacement, but she was quite keen to delay that as long as possible. Earlier that same year, she'd had a right shoulder arthroscopy with a repair to the supra and infraspinatus. And then more recently, earlier this year, she had been diagnosed with hypertension and elevated cholesterol, but she was currently unmedicated for those at the time. So her goals were that she wanted to strengthen her right knee and her right shoulder and delay the need for a joint replacement for as long as possible. And some obvious barriers that we identified in that initial assessment were low motivation for exercise and a dislike of the commercial gym environment. So the next stage of assessment for this patient would be exercise testing. So most people with OA will tolerate symptom-limited exercise testing that's consistent with the recommendations for apparently healthy adults. However, there are some special considerations required. So things like the fact that high intensity exercise would be contraindicated if there's acute flare-up. So for example, maximal exertion exercise testing wouldn't be appropriate during a flare-up. Certain modes of exercise being better tolerated than others. So something like stationary cycling that's a lot more low impact on the joints is better tolerated than something like treadmill walking. Ensuring that we've got adequate warm-up and cool-down periods to make sure that we can minimise any pain and ensure that the patient's able to exert themselves maximally if that's the point of the exercise test. Then in addition to kind of the usual symptoms that we would monitor throughout an exercise test, so things like chest pain or discomfort and abnormal shortness of breath, we've got pain as a predominant symptom and what is actually quite often the limiting factor of the person's ability to exert themselves. And then during testing itself, we've obviously got our usual relative and absolute contraindications or indications for terminating exercise testing, which are even more important with individuals with comorbidities. So monitoring ECG and hemodynamic response to exertion and looking for some of those indications. So things like certain arrhythmias, ST elevation, increasing chest pain or an excessive hypertensive response, and being able to make a clinical judgment about the safety of proceeding with exercise testing if any of those things do pop up. So after that initial interview, I decided that this patient had no contraindications to maximal exercise testing. So I opted to conduct a maximal test using a stage cycle protocol in order to limit the impact the knee pain might have on her ability to maximally exert herself. I chose to implement relatively conservative increases in workload, so 15 watts per stage, as the patient appeared pretty deconditioned in my initial dealings with her. And these smaller increments would allow me to ensure that we could observe that gradual increase in heart rate and blood pressure over an 8 to 10 minute time period, which is kind of the ideal time frame for a maximal exercise test. You can see from the data that I've put up there that we observed a pretty normal increase in heart rate and blood pressure response to those gradual increases in intensity. And although maximal heart rate was slightly lower than what we would have expected for her age, and she did reach volitional fatigue, and that was kind of what she cited as her reason for terminating testing at the end there. So from this testing, we could see that in addition to that, the ECG, we had no kind of changes in rhythm. So we had normal sinus rhythm at rest and then no significant changes during the exercise or recovery phases. And we were able to predict that her VO2 max would be around 21.1 mils per kg per minute based off that test, which fell within that kind of average range for someone of her age and gender, which she was quite relieved to know considering she'd been pretty sedentary for about 18 months prior to this. So then we've also got the other components of the exercise testing where we cover strength, balance, and flexibility assessment. So as you can see from those results, there was some pretty evident strength and mobility imbalances between the left and right sides for both the upper and lower body, which isn't surprising at all given her injury history, but was important for us to be aware of so that we could attempt to correct that imbalance rather than perpetuate it. We also had some below average results for lower body power and endurance, which again wasn't unexpected. And then we were able to observe a decent amount of knee valgus with movements such as sit to stands, with some pain reported alongside. I also conducted a modified functional movement screen, which again just highlighted the limited mobility of the upper and lower body, as well as some poor core control and stability. So based off these findings and also what the patient had hoped to achieve through her program, I came up with the following goals. So firstly, just at a very basic level, we wanted to establish a safe and effective exercise program that she could adhere to and that would promote maintainable lifestyle change. So given that this patient really enjoys recreational aerobic exercise and dislikes the commercial gym kind of environment, we decided that the best use of her time in clinic with me would be to focus on resistance-based training and then perform her aerobic-based exercise in her own time. So this allowed us to ensure that she was consistently performing her resistance training exercises with correct technique, and that we could also progress that as appropriate as quickly as possible. And also helped increase the chance that she would actually adhere to the aerobic component of her program if she could do a mode of exercise that she enjoyed with her partner, with her friends, that sort of thing as well. So we came up with a bit of a plan around using a variety of different exercise modalities, which all had low joint stress that she enjoyed doing. So things like walking, cycling, and swimming as the basis of her aerobic exercise prescription, with an aim to complete 35 to 45 minutes of this 2 to 3 times a week initially. Intensity-wise, I started that at around 60% of her heart rate reserve, which is kind of largely in accordance with the general kind of ACSM exercise recommendations for arthritis, but also takes into consideration some of the barriers to exercise that we identified in her initial screening. So things like ensuring she can exercise outside, can easily access the facilities if required, were key components of that kind of portion of the exercise programming. And then in terms of what I wanted to address during her time in clinic with me, we had establishing a safe and effective resistance training program that would focus on strengthening the quads and glutes to help improve stability of the knee joint and reduce pain, improve function, and allow her to maintain activities of daily living, which she was starting to struggle with. And then we had the other focus of the resistance training portion of her program being improving upper body strength and mobility given her restricted range of motion, as well as her subjective reports of weakness and kind of observable strength imbalances that we saw in the testing that we did. So in terms of the exercise prescription, in regards to frequency, we had her obviously doing her 2 to 3 sessions of aerobic exercise per week. And then on top of that, she came in 3 sessions a week for her resistance training, which were 1 hour in duration with me in the clinic. In order to make that feel achievable and not too daunting to start with in terms of the aerobic portion of the exercise, we had a focus on kind of shifting the patient's lifestyle from being largely sedentary to more incidentally active. So for example, things like walking or biking to the shops instead of driving, as well as some more kind of deliberately scheduled in exercise, such as swimming at the local pool. And then we obviously had the resistance training as well, where we focused on that in her time in the clinic with me. In terms of the intensity of this resistance training, we started with focus more on kind of higher reps, lower load. So we were starting around 50% of her 1RM, and then we gradually progressed that to a more strength-based focus with slightly lower rep range and higher load as she tolerated it. We had a goal of about 150 minutes of deliberate aerobic exercise each week, in addition to those 3 resistance training sessions. In terms of the type of exercise, we obviously know that the most effective exercise programming combines aerobic resistance and flexibility exercises, and that low joint stress activities are the most appropriate in people with OA. So hence why the previously mentioned modalities were implemented. We also had the focus on improving strength and stability around the affected joints in an effort to reduce pain and improve function. I've just put a few example exercises on the screen to give you an idea of some of the exercises we were working on. And then in terms of progression, obviously this always needs to be individualized, and the rate of that's going to vary person to person. But in this case, over the course of her 12-week program, we managed to increase her average weekly aerobic exercise to 4 days a week. And she was doing about an hour to some days an hour and a half of that, purely because she was feeling more confident in her ability to do that and was actually enjoying being more physically active. And then in terms of the intensity progression, by the end of the 12 weeks, she had progressed from about 50% of what her 1RM was that we started with to about 80% of her 1RM going into week 12 of her program. And she also had a lot of improved range and a lot of her exercises, which obviously increases the intensity as well. And then we'd progressed some of the complexity of the exercises to include a lot more functional movements, as well as the incorporation of free weights too. So slight spoiler alert, unfortunately we were scheduled to perform this patient's final reassessment 2 days before we went back into lockdown. So we haven't quite managed to do that yet, so I don't have the post data to share with you, but I'm happy to report that she adapted pretty quickly and quite well to her makeshift home gym, and she's been diligently working away on her home-based program over the last 6 or so weeks. and is very much looking forward to getting back into the clinic and doing her final reassessment when we're allowed to. But in lieu of the kind of post data, I thought I'd just cover off a few of the trends that we've been able to observe over her 12 weeks with us, both through objective measurements that we do every time she comes into clinic, and then also some of her subjective reporting. So the first one would be that generally we've seen a downward trend in her resting blood pressure, which is really good. And we monitor that every time she comes into the clinic, and then also before she leaves as well. So we've seen a general downward trend in both the resting systolic and diastolic blood pressures, and we've been able to communicate that back to her GP, who's pretty pleased with that, and it says she can remain unmedicated for the time being, which she's really happy about. Similarly, she has seen a reduction in her cholesterol levels as well, which her GP is pretty happy with. Subjectively, she's reporting a significant improvement in her upper and lower body strength and control, and she's feeling a lot more confident in her daily activities. Things like gardening for longer and with less pain as well. And she's also just feeling much more confident in her ability to maintain the lifestyle changes that we've been able to implement over the past 12 weeks, which is really positive. So just to wrap up, the main things I wanted to emphasize was that firstly, exercise is a safe and effective rehab tool in individuals with OA, and pain will often be the patient's limiting factor. So the exercise prescription and also assessment needs to accommodate this. These individuals will often have comorbidities requiring additional therapeutic management strategies, which need to be considered when performing exercise assessments and prescribing exercise. And then finally, exercise assessment and prescription needs to be individualized and tailored to the patient based off not only their conditions, but their own goals and also your goals as a clinician. And that's me.
Thanks, Hannah. That's a great case. And it's really, really cool to see the way that this lady's come in wanting to use exercise to improve her OA, and she's getting the other benefits with reductions in her blood pressure and her cholesterol, just kind of reaffirming that it's such a great bang for buck tool that we have. There's a couple of questions for you. There's a couple that are directed directly to you, which you can answer on the Q&A. They've been very specifically addressed. Hi, Hannah, so I won't go there. But some other questions that would be good for you to answer live. So you talked about barriers to exercise. What assessment tools do you use to assess those barriers? You got some stuff for us there?
Yeah, so we can, there's a general kind of barriers to assessment. It lists a whole bunch of different things, and it takes into consideration a lot of different social aspects, things like health literacy, understanding your own conditions and what you think that they might impede you from doing. There's a cultural component to it as well. So it's quite useful, I find, just to get an idea of what people's kind of basic understanding is in terms of their condition and what they're able to do, and then you can work off that from there.
And then the age-old question, which is will have a frustrating answer, which is how is time with you funded, and does ACC help out?
I wish. So unfortunately, ACC doesn't fund CEPs at the moment. So all of the patients that come through here are self-funded, which is obviously quite a big financial commitment a lot of the time for these patients, and obviously isn't a viable option for everybody. But hopefully we will make some progress over the next couple of years and get ACC on board with funding CEP services. And
what about private insurance companies, Hannah?
Yeah, so sometimes people will have some luck if they can kind of petition their health insurance provider. Largely not so much luck, just because we're a relatively new profession within New Zealand, and that kind of tends to be the fallback that health providers will use. But there has been some success, so that's hopefully going to become more and more frequent.
Okay, all right. And look, if you do want to refer to Hannah, you just need to refer through our referrals email address and ask specifically for clinical exercise physiology. That you can see from that case that this is a profession that's got a lot to add for the way that we manage people. And again, look at that really beautiful way that you come in with one problem and you get three managed. So I think that's a really good approach. So thank you, Hannah. As I said, there's a few more questions for you on the Q&A, which I'll let you work through, and we'll go from there. All right. So finally tonight, we've got Mr. Paul Monk, who is a consultant orthopedic surgeon. He's a triple threat, actually, because he is an officer, a surgeon, and a gentleman. So there you go. And it's a very international panel, actually. We've got a Brit, and we've got an Australian, and we've got a Kiwi. So that's very good. If we had an American and a Canadian, we could have Five Eyes, if we're still allowed to be part of that these days. Paul is not only a surgeon, he's an associate professor at the University of Auckland. He maintains an active research element to his work. He works at the University of Auckland. He works at Auckland City Hospital. He consults at Unisports Orthopedics, and he looks at the whole spectrum of problems for the knee and the hip, right from the sport orthopedic injuries through to arthroplasty and arthroscopic surgery as well. So if you want to read more about Paul, because he's one of those guys who's just got an immensely fantastic bio, including the fact that he used to jump out of planes, which I think is pretty cool, then flick over to the Unisports Orthopedics website and check him out. But I won't hold up his talk. He's going to talk to us about some surgical management for knee and hip arthritis. Thanks very much, Paul.
Well, Maria Tofano, thank you for having me along, and thanks to Access for putting these on. COVID's been a real drag all around, especially up here in Auckland, and it's been great to have this connection. So yeah, I'm an orthopedic surgeon. I'm going to take you through, what's cool about these sessions for me is that we see it from all the different angles. So what I'm going to do is give you the perspective that I talk about with patients and what we'll talk to your patients about. So this is the X-ray that I spend the vast majority of my week sitting in front of, which of course is anteromedial knee arthritis. What we're talking about is 80% of all the arthritis I see and we see around the world is anteromedial. It's got a very distinct phenotype. You have an intact ACL. That's important because it keeps the disease in that medial compartment. You have preserved kinematics, but you have that full cartilage thickness, full thickness wear on the anteromedial part of the tibia, which I'll show you in a second. It's intact at the back of the condyle, and the lateral compartment is usually saved. So the point being here is that it doesn't necessarily go to a rip-roaring all through the knee kind of situation. The problem, I think, the hardest part is actually for you guys out in primary care and in physio, is it comes in all different packages. So we see athletes who have a terrible anteromedial knee pain. The person on the right, that's most of us, I think, which is the working age individual who has anteromedial knee pain. And then you've got the elderly gentleman on the side. And of course, they're three very different groups. So you've got the young athlete who's probably got a meniscal problem and he's got some mechanical pain. So, you know, when you're meant to send those in, you've got the working age individual there, probably for me, the most challenging in that they've got a bit of arthritis. What are the options for them? We're going to talk about all this. And then, of course, you've got the older, the more senior members who have got established arthritis. And of course, we're thinking more about arthroplasty there. And so as a surgeon, one of the best tools I've got is the knee replacement, a partial or a total knee replacement. But there's an age-related response, of course. And this is a study we did in the Lancet as I was leaving Oxford, looking at the lifetime risk of revision. So x-axis is age, y-axis is having another one, essentially, the risk of it. And so if you're putting knee replacements into 50-year-olds, you're on a hiding to having a revision. So that halves by the time you get to about 60. So in terms of joint replacements, you know, there is definitely an element of timing, and 60 is a kind of sweet spot for me. But everyone's different, of course. So what I've been asked to talk about tonight is what works. And so the Cochrane Group is a serious bit of kit when it comes to evidence-based medicine. And this is a study which I based this talk around that we did looking at the mild to moderate, the earlier knee OA. So what do we got? What do I talk about when patients come and see us? Well, we've got meniscal procedures. We're talking about debridement or just cleaning it up. We've got suture fixation, where we try and repair the meniscus. So who gets those? I'll take you through it. And I put in brackets meniscal replacement because that is happening. It's not something I do yet because there's an unacceptable complication rate at this stage, but it makes a lot of sense. If we're talking about a shock absorber that needs replacing, it's happening. It's just not quite there yet. We've touched on injectables. There's steroid, which I've moved away from because of there's a dose-related chondrocyte toxicity, which I'm happy to talk about later. Hyaluronic acid, I tell patients this is like changing the oil, the hyaluronic acid derivatives, and then of course PRP, which I'd 100% agree, and there's good evidence to show that it is a good option now. The issue has been that all the trials that have been performed around PRP often have slightly different doses, and it can be hard to compare the results. But there's no question now that for me, if I'm going to do an injectable to buy some time, I'll use hyaluronic acid plus minus PRP if we're going down that route. In terms of cartilage procedures that surgeons do, you might have heard of Macy, AC, and Oates. This is chondrocyte implantation. A clever thought, but it hasn't really performed financially or in terms of outcome as well as some other simple procedures which can be compared to, like microfracture, which is a procedure where we make a small puncture hole in the surface of the cartilage to allow, people call it marrow venting, to allow that good stuff from the marrow to come out and form new cartilage. That's the theory. Specifically, when we get to the operating room now, I'm going to go through a procedure called HTO, high tibial osteotomy. So it's an extra articular, it's outside the joint procedure, which we can do in people who are too young for a knee replacement. And then, of course, the intra-articular procedures, we've got total knee replacement, and my favorite operation, the unicompartmental knee replacement. Okay, so but what actually works? That's what we really want to know. So this is how I think about it, my biased mind. So on the left there, that's our 18-year-old beautiful pearly white cartilage knee. This is an arthroscopy. So at the top, you've got a femur. At the bottom, you've got tibia. And that's your shock absorber, the meniscus, right in the middle there. And so about age 20, 25, we all get this twisting injury and we tear the meniscus. And that's what it looks like when you pop the keyhole surgery, the arthroscope into the knee. You've got a little tear there, and that's where you can get your mechanical symptoms. That's the locking, the giving way. And so why does that happen? Well, just a quick revision for everybody. One slide, don't worry, I won't dwell on it. But the meniscus is an extraordinary structure, C-shaped ring of cartilage with incredible design in terms of the circumferential fibers, which take up that hoop stress, longitudinal fibers. And so it's a perfect shock absorber. It's an amazing bit of kit, which we've never been able to reproduce. People have tried it with spider silk and all sorts of different methods, but they just hasn't done the job like the natural one does. It's so important that back in the day, in the bad old days, when people used to do meniscectomies, if you take out your medial meniscus, your contact area dramatically increases, of course, but the pressures are up to 235% increase going through your native cartilage. So the meniscus is such an important structure. In terms of diagnosis, I'm preaching to the converted here. This is the classic twisting injury. The examination, the classic findings are locking and giving way, that joint line tenderness. Not much is going to show up on an X-ray. And so the next step for us all is to get the MR. The management, the whole point, the theme of this is what a message I want to get across is we try and repair it or save it because of that load sharing device. To give you an idea of why in younger patients, if you take out the meniscus, we're left with evidence of osteoarthritis within 5 to 6 years. So there's a classic picture of an MRI of a bucket handle tear. Those two little, let's call the fast forward sign, those two little black parts in the joint space. The one posteriorly should be right at the back where there's just a ghost of the meniscus. There's many different types. The worst of all for the surgeon, of course, is the radial one, which is like a complete split, which is most challenging, I should say, to fix. And in terms of techniques, we can move sutures from the inside to the out. You can do it. There's now new novel suture devices with a knotless system, which you can do all inside, or if they're really tricky ones in odd positions, we can come from the outside in. And to give you an idea, this is what I'm talking about. So this is a view of a longitudinal tear in the posterior medial part of someone's meniscus. That's my probe there. You can feel on the inside, and you can feel you can feel it all the way along. It's all the way through the meniscus. That is a diamond tip rasp, which we're actively rocking up the surface to make it bleed, to help it heal. And these are all inside knotless systems. So you pass the suture through the meniscus, and then you literally just pull on the string and it tightens, it snugs it all back down. And that's how you do them, and that's a meniscal repair. So what's the point of the meniscus is wherever possible, we want to repair it. The vast majority do heal. We think that's going to help in terms of arthritis, but this is a relatively new in the big picture. We need to figure out the final studies in 20, 30 years time. Has it actually worked to lower the rate of OA? Now there's a somebody mentioned in their other slides before, but there's a take-home message here as well, that if you've got established arthritis, repairing the meniscus is not going to delay the course of that arthritis, but it does work in terms of mechanical symptoms. And so the pathway remains physio, medications, and then the MRI if you're not winning, and then we're happy to see them. So moving on to the working age individual, this is probably the most challenging for all of us, is that you can see some arthritis on their x-ray, but they're too young for an arthroplasty. So we're talking about now moving, that was the 18-year-old top left with a tear. And then you see, as you could progress through the arthritic knee, you get this more yellowy, degenerative, rubbery tissue. And if you pull back that medial meniscus, you can see that bare area of cartilage in the bottom right. That's anteromedial knee OA. That's what it looks like. So you've got this halo of relatively intact cartilage around a bare area of bone. So what are you going to do with that? Well, this is a procedure which we've developed. High tibial osteotomy has been around for decades, but we've figured out a good way of doing it in Auckland, we think. Essentially, it's an operation where you make a cut in the bone and then swing the bottom of the bone out and put a plate on. So you're realigning the weight-bearing axis of the limb. From in the left-hand picture, it's overloading the medial compartment. And by moving the axis, you can move it laterally and offload the painful compartment. As a surgeon, of course, you've got complete control over where you want to put that line. And this is where the interesting part comes in. So classic bit of orthopedic literature back in the 1970s, a guy called Fujisawa did a whole bunch of these and went back and looked at which ones he thought worked well and said, aha, I put them at 62. And then wholesale, the orthopedic industry for 30 years has used this Fujisawa point, it's called, at 62%, based on not great science. And in practice, we didn't really understand exactly where everyone should go. And so with that in mind, at the Bioengineering Institute, we've been trying to define this patient-specific correction. So I'll just take you through it very briefly. We've got a population-based statistical model, which is essentially a library of how everyone loads up their legs. There's over 900 people in it. So we can move our model to your patient. So we take an MRI scan and the x-rays like this. So we used to do all our planning on just the x-ray on the left, and this is what I use on the right now. So the x-ray is the shadow in the background, the model's the bones, and the MRI is the colored cartilage. And so with that, we get a very good idea of how the patient stands and loads up. And that tells you two things right there. Number one, how good the meniscus is at absorbing load, but also where they're loading up predominantly through their medial compartment. With that in mind, I can then plan my surgery. So top left, 27 is where they come into the office. 50 is where people in Oxford used to do it. 62 is Fujisawa. You're offloading it a bit more now. But if you really want to offload that person, you've got to take them out to much further across than you'd normally think. In reality, everyone's a little bit different, but there's a sweet spot where we need to start planning people. From there, we do the surgery in the computer, as it were, and then we 3D print that air wedge. That's the bit I take into theatre. I'm doing one tomorrow morning. So this is the guy for tomorrow. So we take in that patient-specific wedge, make the cut, and then use the wedge which settles his leg in his ideal correction. The plate goes on, and that's the operation done. He's on the exercycle by 2 weeks with this new method. They're walking by sort of 3 or 4 weeks unaided without the crutches. And some of you guys on this webinar have actually been helping us out, so thank you for that. And the strength work begins at 8 weeks, and it seems to be about half the time it used to take with the old way of doing it. So in summary, so far we've talked about the multidisciplinary team, weight loss. We've talked about injectables. Nobody's mentioned bracing and insoles. They do have a benefit. But in terms of operations, we've got the meniscus, we've got the high tibial osteotomy, and just very finally, I just want to touch on in the last 2 minutes on joint replacement. So we've got partial knee and total knee. So now we've moved into beyond this working age individual to the classic older patient who comes in with a painful medial compartment. This is an extreme case, bow legs, very painful anteromedial knee OA. And sorry about the gross picture, but if you open up that lady, this is that lady's knee. if you open it up, you see this bare area of ebanated bone in the medial compartment. In the middle, you can see her little ACL just hanging in there. And on the outside, she's got intact lateral cartilage. That's what lateral cartilage, intact cartilage looks like. So you've got two options with her. And this is, I'm very biased. I trained in Oxford, but this is an implant, a medial compartment, unicompartmental knee arthroplasty, it's called. So it's a partial knee. It just replaces the worn compartment because the other compartments aren't affected. Or you have a total knee replacement. And you may ask, well, what's the difference? So this is what it looks like on MRI. You can see the lateral side is completely intact. The medial side is totally shot, and that's what the post-op X-ray of this guy looked like. So the difference is, if we did a study looking at huge numbers from the registry in the UK, if you have a total knee versus uni, the uni has lower mortality. It's tiny numbers. If you tell that to a patient and they're sold, but the length of stay is much less. The readmissions are much less. But in terms of things that go wrong, blood transfusions, strokes, heart attacks, DVTs, they're all twice as high with a total knee replacement. So it's kind of a no-brainer for me, but perhaps the most important is what the patients think about it. They're 3 times pretty much more likely to be satisfied with a partial and twice as likely to tell you that it feels pretty much back to normal compared to a total knee. And that's me, really. I'll finish there. So we got plenty of options.
Yep, I've got a couple of good questions for you, Paul. Thank you. Thanks for that. It's just a great run through of those options. And I've got a couple of questions to put to you. As we answer these questions, I'm going to launch our nightly poll, which you can work through while we answer these questions. But so can you talk to us a little bit about the success rate, or at least perhaps the indications for meniscal repair compared to meniscectomy? That's first up.
So wherever possible, we'll try and repair it. There comes a time, if you think back to those 4 pictures of those arthroscopies, there comes a time where it's irreparable. If it's a flap tear it's literally flapping in the breeze and there's no way it's gonna heal, those are the ones that we would do a meniscal debridement. It's very rare we take out the whole meniscus now, full meniscectomy. So it's debridement versus repair. But if there's any chance of it repairing, we'll give it a try.
Great. And so what about distal femoral osteotomies? Do they have as good an outcome as high tibials? Obviously different indications, but how do they go?
Yeah, distal femoral osteotomy is often used to realign for valgus disease. So we've talked primarily about varus, the anteromedial bow. Distal femoral osteotomy, very successful, much less common unless the series is all, the series, we're talking about cohort analysis, level 3 data, but yeah, it's an effective way of buying you time. Yeah, these are, I describe them to patients as this, we need to do something to get you between now and your knee replacement, because they're just hanging out for something to be done. But they're both effective ways of doing it. And we've actually put a few of them through our software and they seem to work really well.
Great. What sort of range can you get with a uni?
So the range is better than, I get them back to what they were. So from 0 through to 120, 130. So there's 2 people in my mind that I've ever had a problem with, if I'm being completely honest, and they were both people who'd totally forgotten that they'd had a uni, that they'd had a knee replacement, and they're doing some weird yoga position. And so you just don't hear that with a total knee. So the range pretty much gets back to what they had pre-disease, I should say.
The old weird yoga position. Yeah, that old chestnut. Okay, a couple more questions for you, Paul. Would you do an HTO and a uni compartmental replacement on the same knee?
Great question. That's really so there's a study by Johnny Rees in Oxford which showed that the outcome as a salvage doing a partial knee after an HTO doesn't work as well as it isn't worth it. You get the same functional result as you would with a total knee after an HTO. So the series goes meniscus, HTO, total knee.
Okay. Question here: Don't HTOs cause increased force in the healthy compartment and therefore cause it to break down quicker? Is that one of the concerns?
That's why I go to great lengths to plan how much load you're going to put through the lateral compartment. So what we're talking about is a 50-year-old individual who's got a failed medial compartment. So it's taken 50 years for the medial compartment to wear out, and they've not been loading through the lateral compartment. So the next question is, how long is it going to take for the lateral to wear out? In the terms of the studies, you get a good result, a very good result, out to 10 to 15 years. So for the 50-year-old, that takes them to the 65, and now you're more in a better range. But the results, the early results we're getting by planning it in a more sophisticated way, we're hoping is going to last even longer, but time will tell. But yep, you are absolutely reliant on that healthy lateral compartment. And in fact, before I do any of them, we do an arthroscopy while they're asleep before we start the HTO, just to check, and I get a probe on that lateral compartment. I want to feel the cartilage and know they've got good cartilage. And it's a real heart sink situation, but one time we haven't been able to carry on because the lateral cartilage just wasn't going to stick up to it. So
Right.
their next operation is the total knee.
Paul, for your young ACL reconstruction patients, what do you tell them about the chance of developing OA in their knee by the time they hit 40s and 50s?
So the evidence is very clear that the injury, whether you fix it or not, dictates whether you're going to get arthritis later on. So having an ACL rupture, you can set the clock to having radiographic OA changes in 20 years. Everybody will have them. That doesn't mean you're all going to need a knee replacement. And often people go 40 years sometimes, they get all the way, they just live with that pain, as Adam was talking about. But I tell them within 20 years, whether I do a ACL reconstruction or not, you're going to have some form of arthritis in that knee. Everybody.
All right, and this is the last question we'll take from tonight before showing the poll results. It's really for all of us recently. Is anyone prescribing CBD oil or coming across people prescribing CBD oil? You haven't got much experience with it. I'll start off and say I'm not. I haven't really been given much education on it. I'm seeing some patients who are sort of procuring it from wherever they want to, and anecdotally seem to be enjoying it. But Adam, you're down in a part of the country where this might be happening a bit more frequently.
No, I have seen it down here a few times. People have switched to it just as something else to use. I know there's some good research being done in Melbourne by Stephen Hall. They're looking at CBD oil for osteoarthritis. And I don't know the results of that, but that's the that's where to look out for the research for that. But no, I haven't prescribed it again. I'm not sure how you'd prescribe it. So,
are you, Paul?
Yeah, I don't use it. Again, I'm waiting to see the trials and everything else. But anecdotally, there are people out there that are using it. They're finding it, and they're getting good pain relief from it. Pain's a multimodal thing. I don't mind what they're using to get their acupuncture. If it works for them, fantastic. There's a very good question that's just come up from Tracy asking, which I'd just like to cover off on, which kind of links all the talks tonight. Education, exercise, and weight control, the best in practice. How reliable is the imaging? That is an absolutely key point. We treat the patient, not the X-rays, right? So I'm always amazed by that when we look inside a professional athlete's knee. So the rugby guys, the league, the Warriors, they've got a fully arthritic knee, but they don't feel it. And why? It's because they've got that incredible constitutional strength which they've been keeping up. So it's a great point by Tracy. Yeah, we treat the patient, not the X-ray.
And this is definitely the last question, but it's also for you, Paul. Do you have any specific? Well, actually, also for you too, Hannah. In this setting, any specific load progression guidelines for your HTO patients post-op, Paul?
Yeah. So in terms of the load progression, I tell them that it heals like a fracture. And the fracture takes 6 weeks minimum before you're getting any of that good callus formation in there, with or without bone graft. And that as pain allows after that, we get going. So we start loading up as we would from 6 weeks onwards. So I use crutches for the first 6 weeks, foot flat, and they don't want to stand on it for the first few weeks. And then they progressively load through. And by 3 months, they're absolutely flying. So they take themselves off their crutches at about 6 weeks. It's just not painful.
And Hannah, anything to add there? You've worked with some HTO patients, obviously.
No, I think that pretty much covers it quite well. It's all about kind of that gradual approach to it and making sure that you're not overloading too quickly, but also encouraging people not to kind of hold back too much as well.
Great.
Paul, can I ask a question for this for my trailblazers down here? Having a hemi arthroplasty, getting back to skiing, running, tennis.
So the classic are the referees who just will not stop playing soccer. And so what I tell people is, so we know there's good papers out of Oxford. David Murray's written one about activity. Impact loading on an artificial knee is not a great idea. Skiing, tennis, squash, no problem at all. Doesn't seem to be an issue, but it's not a great time to take up long distance running after you've had a partial knee replacement. But yeah, you're surprising. The reality is people do what they want to do. They listen to you to a certain extent, but if they want to run, and there's people out there running on these things, they just wear out quicker.
I had a guy come in the other week who's had bilateral hemis, bilateral total hip replacements, and now looking at an ankle fusion because he can continue to ski.
Yeah, skiing is seems to be fine. Yeah.
Yeah. I always use the analogy: you don't throw rocks at glass houses. So with running,
that'll do, Adam. That'll do. The poll is in, and I'd like to let you know that that's pretty even split of how many people thought there were more coronavirus cases than South African kicks from hand. I couldn't drill down into kicks from 9 to work out the box kicks, but I'll let you know that on Wednesday, obviously, we got the miserable news that we had 49 community cases of coronavirus in New Zealand. So here's a technicality. I didn't include the MIQ ones, but only 38 kicks from hand in last week's test match. So if you went for the coronavirus cases, you were correct. So thank you to you all. That wraps it up. A momentous night. It's the first time I've heard Adam Castricum present and not give either an AFL anecdote or mention Sean Burgoyne. So you've all witnessed that. It's a big night for all of us. Thank you again for your support and coming online on a Thursday night. As I say every week, we're open here at Axis. We're really keen to help. We're getting to a phase now in level 3 where we are starting to see people face to face on an as-need basis, because there are people out there now who are in a lot of pain, who are struggling, and their healthcare may be starting to deteriorate. So much like Paul talking about trying to triage patients who really, really need care and support. So look, again, I don't know if we'll be back next week. Who would know? I guess us Aucklanders have found out that we're not leaving Auckland regardless of anything. So if we're lucky, you might get a school holiday trip to Motat or something else that really, really gets you going. But if we're back next week, we'll let you know. Thanks again for having us, and enjoy your night and have a lovely weekend. Thanks to all our panelists as well for their expertise and their time. Cheers all.